After listening to very important but all non-academic lectures, let's come back to business. Let's come back to things we do best all the time. So, if you all know the birth of plastic surgery has happened in India. Our own Sushruta have presented or described many procedures in plastic surgery. But since it is not an organ-specific faculty, many of us don't know what really comes in plastic surgery. So I thought of arranging things in A to Z update for plastic surgery, and I have arranged topics from A to Z. I am telling you in short. So from A, axillary breast or breast hypertrophy is a very common problem females face. There is embarrassment of using sleeveless dresses, underarm heaviness or fungal infection or discomfort is the usual complaint, and simple liposuction without any skin excision can give terrific results. Even the bigger axillary fat hypertrophy can be managed only with liposuction, and it does not require skin excision at all. Then another topic is from A, anal sphincter reconstruction. Anal sphincter is usually destroyed after chronic constipation or after surgery for hemorrhoids or fistulas, fissures, and then comes role of a plastic surgeon. Anal sphincter can be reconstructed with using a particular gracilis flap. You can see the gracilis flap is harvested without disturbing its blood supply. It is twisted around the anal opening, and it is inserted onto the ischial tuberosity. And since it is functioning muscle, we can achieve control over the feces passage. From B, very favorite topic of plastic surgeon, burns and burn sequelae. So whenever we see a burn patient, we apply silver sulfadazine and ask patient to continue dressing. But usually what happens, they do not wash the previous day's silver sulfadazine and it forms a SR like bad SR like this. What I prefer is to excise the SR and dress the wounds with collagen. It heals beautifully within a week or 10 days. And believe me, the scar also is better if we apply collagen. But many times patient comes with burn sequelae. So now this lady has presented to us with a bad scar, inability to stretch her neck, inability to extend completely. So what she needs is she needs a soft, supple and skin which can be of better color match. So we plan to provide her skin from the lateral chest wall, which is a better color match for such cases. It is called thoracodorsal artery perforator flap. So what I did is excise the complete scar and replace it with the free flap harvested from the lateral chest wall. You can see she has complete neck extension. Her color match is very good. Similarly, this patient had a bad scar. Luckily, he didn't have any contracture, but the scar was not very good looking, and it was hampering him psychologically. So we plan to excise the complete scar and replace with the same flap which I described in last case. Sometimes they present with burn contractures like this, so we have to excise the whole scar. Sometimes we have to reconstruct tendons and cover it with a free flap whenever there is tendon exposed or we are reconstructing tendons. So we can reconstruct these things with skin graft if the tendon or joint is not exposed. So you can see the soft, supple and good contoured flap over the ankle. We have to provide good skin over joint so that it won't lead to further contractures. Like this, in this baby, the contracture is released and it was resurfaced with a cross finger flap. So now, whenever a patient comes to plastic surgeon, they don't want scar. So we are not magicians to do surgery without a scar. So what we do is we hide our scars whenever possible. Like in this case, the lady presented with a osteoma. So I could have done the excision with putting the scar directly on the osteoma, but I planned the scar in the hairline. So the osteoma is excised, but there is no visible scar. Similarly, this young girl who was present with this large lipoma, had I excised the lipoma using a incision on directly on the most prominent portion of the scar, on the swelling, it would have given a bad scar and she would have cursed me for life. But I excised it through a axillary incision, and since she is so young that she won't even remember that she had a swelling like this. Similarly, this is a cyst excised through a lateral nose incision. The incision is hardly visible. Many times patient present with a compound fracture like this, we have to plate it with the exposed bone is to be covered. Many times such patients need secondary procedure like bone graft or tendon reconstruction. So we have to provide a full thickness cover. In such cases, we usually do free flap harvested from thigh or back or sometimes calf. In this case, we had reconstructed this particular patient with a flap harvested from a thigh. The bone is covered, it can be plated or bone grafted. Similar patient. Now this patient was reconstructed with a flap harvested from his calf. This is called pedicle flap. Both possibilities can be done, pedicle flap or free flap, depending on the nature of the injury or need of the injury. Diabetic foot reconstruction is an important topic in plastic surgery. So, debridement is the crux of giving good result to the reconstruction. So, just thorough debridement and a simple skin graft can achieve wonder results. Sometimes patient present like this with two gangrenous toes, inflammation, so we had to sacrifice the toes in emergency. But you can see the upper image where the granulation is not very great, because we had to operate this patient in emergency. The vascular assessment was not done prior. So once we do vascular assessment, we saw that anterior and posterior tibials were blocked. We got the intervention done. Once intervention was done, you can see the difference in the granulation. So this wound is ready to cover. So we covered it with a gracilis muscle flap, free flap, and covered it with a skin graft, and this is the final outcome. But now this patient can be grafted easily, but since it is a weight-bearing area, the graft will break down frequently. So we have to provide a full thickness skin cover, and which can be done with a micro-vascular flap. Sometimes patient present with a diabetic hand infection like diabetic foot infection. We have to debride it thoroughly. In such cases, when the tendons are desiccated dead, we have to excise the tendon, reconstruct the tendons using tendon graft, and provide a full thickness cover. So our field lies in saving your foot or saving your hand, and not in amputating it. Many times declaring injuries are our daily practice. If you see this ghastly injury, you will feel what is, first thing is, you have to assess what is lost, what is the need of the reconstruction. You will be surprised that it was just a superficial injury, and the thorough debridement and the proper assessment. After the proper assessment, it was simply grafted, and patient walked away from hospital after just 3 weeks with such healed wounds. Elephantiasis is, though the filarial incidences has decreased, elephantiasis is increasing after, especially after breast cancer surgery or groin node dissection. Unfortunately, patient comes to us with grade 3 elephantiasis, and we don't have any other option but to debulk it and excise the excess skin and excise the excess tissue. Like this lady was denied treatment for so many years because she was wandering with physicians and physiotherapists, and she was not aware that this can be dealt with. So we just did a little liposuction and closed it, and she was back to the social life very soon. From E comes earlobe repair. So many of the ENT surgeons, general surgeons also do earlobe repair like plastic surgery. But when the earlobe is completely torn, it is high likelihood that if you repair it simply, it might recur again. So what I prefer is harvest a ear cartilage from the same ear and put it into the pocket developed between the skin edges. So next time when we pierce the ear, it can be pierced through the center of the cartilage, and it does not recur, or at least it will recur after many years. Sometimes they use some chemicals, or they go to wax and sutureless techniques they do, and they come to us with a scarred ear lobule. So in such cases, ear lobule can be reconstructed using a simple flap from the cheek, from the area just below ear. You can see the final result. Facial palsy is very unique topic. Many of the times they don't know that plastic surgeon can provide you with the reanimation or proper eye closure. They go to neurologist or neurosurgeon or physiotherapist, and they are not referred to plastic surgeon. Since it is a time-based reconstruction, it is important to see the patient in time. This is a case of corneous gangrene. Otherwise, this wound would have healed in no time. But since it was presenting contracture in the groin, he would not have been able to sit in the Indian toilet or cross-leg. So what we did was just contracture release and covered the defect with a particle flap, and he was ready to sit down, cross-leg or squat. Now gynecomastia can be really disturbing for especially in young male. So what is in excess is in fat and the gland. So we have to tackle both. A tiny incision under the breast can excise the gland, as well as we can liposuction through the same incision and give nice results. You will wonder the nipple size on the unilateral gynecomastia is so big, but once the liposuction is done, it shrinks to normal size in no time. Nail bed can be grafted and given a good appearance like this. You cannot even make out that the nail has grown to normalcy, and even the donor side is not very obvious. From H comes hydradenitis. Hydradenitis is a chronic suppurative lesions in axilla or in groin where there are apocrine glands. So what it needs is just complete excision of the skin up to the underlying muscles or underlying structures, so that the culprit apocrine glands are completely excised and provide a full thickness cover. So it can occur in axilla, sometimes inframammary region or groin. It can even involve labral region. So even suprapubic region needs excision and grafting or flap in such cases. Inflammation and wounds are part and parcel of plastic surgery. So this patient had gone to many surgeons. It was grafted again and again, but I excised the complete ulcer up to the base, and it was back for some time, and then the graft take was 100%. Some reconstruction are just like wow, you feel like what I've done some wonder. You cannot describe it, the feeling once you reconstruct such patient. So this patient had presented with a degloving injury of hand. It can be grafted, it can be flapped from anywhere from the body, but the quality of skin of hand is unmatched by any other skin. But you can get similar skin only from foot. So what I planned was a flap from foot based on medial plantar artery, and the result is wonderful. You cannot even make out that this is not a hand skin. Similarly, this patient presented with a hook nail. It was bothering this girl very much. So what we planned for was a partial toe transfer. Because not only nail but the distal phalanx pulp of the finger is lost. So we provided all these structures, and this is the final outcome. Now this patient presented with a basal cell carcinoma of nose, and it was excised, and this was the picture before we started to reconstruct. So it needs cartilage, skin, mucosa. So we provided all three structures from the ear, and the result is fantastic. Keloid there is no answer for keloid, but sometimes intralesional injections, intralesional excision can give good results. Lacerations are to be assessed well, and we can, if we respect the anatomy, respect the tissue, we can do a wonderful result. Like this nose scar is hardly visible. Liposuction is very common topic for all the plastic surgeons, but this has presented with a isolated area of lipodystrophy, and liposuction works wonder in such cases without skin excision. This patient also had isolated hip fat lipodystrophy, and it was liposuction. Lymphangio circumscriptum is a lymphatic malformation, usually only small islands surface of the skin, but the whole lesion is under the skin. So you can excise it completely and reconstruct it with the flap. Reduction mammoplasty are very routine surgeries nowadays. Females present with not just embarrassment of fitting into proper clothes, but the intramammary fungal infection or discomfort to do daily activities is very discomforting. Even after BCS, we have to reconstruct the breast to provide contour maintenance, and MRM can be reconstructed with various options of flap. With the current this thing that lymphomas are common after breast implant, augmentation mastopexy with fat grafting has come up very large, and the advantage of getting liposuction from some other area is just added advantage. Like this lady was injected with 200 cc of fat sucked from her tummy. Microsurgery is our day-to-day practice, but I can go on talking on microvascular surgery for hours. Nerve reconstruction is my forte, and that is in total a different lecture per se. Many times patient present with a tibial defect, long segment loss, so we can reconstruct these long segment gaps with fibula flap. And once the external fixator are out, the fibula is fractured, and it hypertrophies to the extent that we cannot make out that this tibia, fibula, and patient can walk, weight bear very well. This is a unique case of necrotizing fasciitis of breast, secondarily involving sternum. Probably the sternum was also osteomyelitis because of thrombosis of internal mammary arteries. We have published this case, and this is one of the very few presentation of necrotizing fasciitis of breast with sternal osteomyelitis all over the world. After the advances in open heart surgery, like they have started using internal mammary arteries for bypass, we are coming across sternal osteomyelitis very frequently. So what we need to do is take out all the wires, debride the dead bone, debride the dead skin, soft tissue, and cover it with a nice healthy tissue. Either sometimes omentum is used to cover, or pectoralis major muscles are used to cover and double press the sternum, excise sternum. And skin is not never an issue in such cases because the skin is not lost many times. Pilonidal sinus, the crux of reconstructing pilonidal sinus lies in the suture line not falling into the midline again. So what I do is I mark the inferior gluteal artery perforator and base of flap on the inferior gluteal artery. You can see there is no suture line in the midline except for the topmost point of the flap. Bed sore, there are many options for bed sore, but I just mentioned 2-3 flaps for the bed sore. Replantations and revascularization are very close to my heart because it is indeed a very challenging but very rewarding surgeries. I'll show a few of the examples. Like this is distal DIP joint level amputation where the arteries are very minor in size, and it feels very nice once you see the pink finger. This is a 4-year child with replantation of wrist. This is another lady with replantation. We had to sacrifice the elbow joint, but her hand and fingers are working normally. So after soft tissue sarcoma, our role is to reconstruct the lost tissue or lost skin. Like this recurrent soft tissue sarcoma, after the excision, the femoral vessels and all the femoral vessels were exposed, and all the mass of the back of the thigh was lost. So we reconstructed it using a free flap harvested from the contralateral thigh. Like this, soft tissue sarcomas can be excised and we provide cover. Now, tendo-Achilles can be repaired if they present after the acute laceration within a week or so. But if they present late after chronic or closed tendo-Achilles rupture, then we have to mobilize the tendo-Achilles to close the defect. But there is a unique problem with tendo-Achilles being a less vascular area. We very frequently come across the skin complication, and we have to provide some cover either local or if the tendon is also desiccated and lost, then we have to reconstruct it using a flap. Lipoabdominoplasty is very common plastic surgery nowadays. This is a case of bone transfer. This is a patient from Virar. He had presented after thresher injury. He had lost all his 4 fingers. We provided with a cover, full thickness cover, and we harvested 2 toes from second toe from each foot and reconstructed the hand. And now this is the final outcome. He can do almost everything, right from writing to riding a bike and doing everything in his palm. He can do. Through few uncharted terrains, like we can do surgeries for migraine, paraplegia, genital surgery. Obviously, I can't show result because of privacy issues. White patch surgery also can be done with plastic surgery. The white patches are excised and new skin can be. Xerophthalmia can be reconstructed using re-innervating the de-innervated cornea from the contralateral side. Gender reassignment surgery is very common these days. You can see the reconstructed phallus, and Z-plasty is very important tool in our armamentarium. Wherever we see a contracture, we see if a Z can be fitted there. Thanks for listening patiently. Thanks to the organizer for giving your